The opinions expressed by ResusLogix or Dr. Montano do not necessarily reflect the views or positions of his employer, past or present.
Welcome, everyone. We're going to do a super high-yield briefing today, basically your journal club in a box for the busy ICU team. We are breaking down 3 absolutely essential papers on some of the biggest challenges we face every single day, from ventilating complex ARDS to managing severe influenza. Let's jump right in. So here's the game plan. First up, we're going to talk about ARDS and why treating every patient the same might actually be holding us back. Then, we'll take a really deep dive into the cellular battle that decides whether a kidney recovers after an acute injury. And finally, we'll get super practical with the latest on antivirals for severe flu. Each part is designed to give you evidence-based takeaways you can use on your very next shift. Okay, let's get started. First up, we've got a fantastic review from the journal Critical Care that really challenges us to rethink one of the most common diagnoses we make, acute respiratory distress syndrome. This paper is all about moving past that one-size-fits-all mentality. So this paper kicks off with a really powerful question, one that should make all of us stop and think. By treating ARDS as this single, uniform disease, are we missing chances to personalize care? Or, even worse, could we actually be causing harm? This really gets to the heart of our current approach.
And look, this is why it matters so much at the bedside. Our standard lung protective strategies are great, but they can lead to pretty suboptimal outcomes if they're ignoring what's really going on with that patient's specific pathophysiology. Tailoring our approach isn't just an academic exercise. It could literally be the key to improving survival.
So, what did they find? Well, the big thing is that ARDS is not one disease. It's a whole syndrome, and it's different based on its biology, how the lungs are actually functioning, and even when the injury happened. The authors point out these distinct subphenotypes, like a hyperinflammatory type that might do great with steroids versus a hypoinflammatory type that might not at all. These different flavors of ARDS can respond in completely opposite ways to the stuff we do every day.
But, let's be realistic here. This all sounds amazing, but the review is super clear that we're not quite there yet. We don't have a simple, standardized test we can just run at the bedside to identify which subphenotype our patient has. So for now, this is more about changing how we think about ARDS, not an immediate change to our protocols.
Okay, so what can we do right now? Well, we can start tailoring our ventilation based on the cause of the ARDS. For ARDS that's directly from pneumonia, the lungs are often stiff, not very compliant. So using higher PEEP makes sense to try and open things up. But for ARDS from something like sepsis, the lungs are often more compliant, so starting with a lower PEEP might be safer. The real key here is to constantly watch that driving pressure and be ready to adapt your strategy as things change.
So here's the big takeaway, the one-liner you need to remember. ARDS is a spectrum, not a single disease. We have to match our ventilation strategy to the patient's specific pathophysiology, not just the diagnosis on their chart. All right, let's shift gears from the lungs to the kidneys. Our next paper is from the Journal of Clinical Investigation, and it takes us deep into the cellular world of another ICU heavyweight, acute kidney injury, or AKI. And this paper asks a really fundamental question, something that goes way beyond just watching the creatinine go up and down. What is actually happening to the kidney cells during an injury? And what's that tipping point that decides between a full recovery and the slide into chronic kidney disease? And this is so important. Why? Because right now, our management of AKI is basically just supportive, right? We're managing fluids, stopping nephrotoxic drugs, maybe starting dialysis, but we're not actually treating the injury. To get there, to develop therapies that can actually fix the problem, we have to understand this process of injury and repair at the cellular level. So what's really fascinating here is just how specific this injury can be. The paper zooms in on the kidney's workhorse cells, the tubular epithelial cells. And after an injury, there's this critical battle that takes place. The immune system can either jump in and promote healing and repair, or it can keep fueling inflammation, causing cells to die off. And that leads to scarring or fibrosis, and that's the road to chronic disease. Now, the paper is honest about a major hurdle in the field. We've got these great animal models that give us incredible insight into what's happening inside the cells. But turning that knowledge into treatments that actually work in humans, man, that has been a huge challenge. It's that classic bench-to-bedside problem. So, what does this mean for us at the bedside today? Well, it's really about changing our mindset. We need to recognize that not all AKI is the same.
After a big ischemic hit, for example, we should expect that the damage is concentrated in those vulnerable tubular cells. And when we're talking to families about prognosis, we can explain that the slide into chronic kidney disease isn't just a passive thing, it's an active failure of the kidney's own repair systems.
So if you remember one thing about AKI from this, it's this. Recovery is a cellular battle. If repair wins, the patient recovers. But if inflammation keeps going, that's what paves the road to chronic kidney disease. Okay, for our final paper, we are getting into the nitty-gritty of managing antivirals for severe influenza in the ICU. This is based on a review in Clinical Microbiology and Infection, and it's a practical problem we all face every single flu season. And the authors here are tackling a question that, let's be honest, we all struggle with. In our sickest patients with the flu, what's the best way to use antivirals when the evidence is kind of shaky and the risks of getting it wrong are so high? And this is a huge deal because our standard playbook for the flu can completely fall apart in the ICU. Poor gut absorption in a patient who's in shock or has an ileus could mean they're getting almost no drug. And all that viral replication going on, that's just a perfect breeding ground for resistance. This really gets to the heart of the problem. Yeah, oseltamivir is our go-to, but all the evidence we have in the ICU is just observational. No solid randomized controlled trials. And even worse, we often have no clue if our sickest patients are even absorbing the drug we're giving them. And on top of all that, resistance is not some rare thing. One study found it in almost a quarter of patients who weren't getting better. That's a huge number.
So let's just lay it all out. What are the pros and cons of oseltamivir in our world? Well, on the one hand, every single major guideline says to use it. But on the other hand, we have no real ICU-specific trial data, we can't be sure our patients are even absorbing it, and the risk of resistance is very, very real. Okay, so what do we actually do? What's the plan? Well, here's a pretty clear 5-step approach you can use. First, start oseltamivir immediately. Second, if they're not better by day 5, think about a longer course, and this is critical, test for resistance. If you find it, you've got to switch therapies. And finally, never ever forget to hunt for those bacterial or fungal co-infections, which are incredibly common in these patients.
The big takeaway here is all about being proactive and vigilant. In severe influenza, you have to treat early, and you have to stay on your toes, because poor absorption and viral resistance can make your treatment completely useless, and fast. All right, let's wrap this up with the big teaching pearls from today. For ARDS, match your vent strategy to the patient's specific pathophysiology, not just the label. For AKI, remember it's a cellular battle between repair and chronic inflammation. And for influenza, treat early and be super vigilant for signs that your therapy isn't working because of absorption or resistance. And to finish up, I want to leave you with a few questions to take back to your team, to really spark some discussion on your next rounds. How can we start trying to identify these ARDS subphenotypes? Does this cellular view of AKI change how we talk to families? And should we have a protocol for flu resistance testing? Take these back and keep the conversation going. Thanks for joining.